Thank you, Karen, and thank you to Deborah and ACT for organising this evening. So we've known for nearly 100 years that both children and adults with intellectual disabilities suffer from very high rates of comorbid psychiatric disorder. But as we've seen the increase in prevalence in ASD, particularly over the last 20 years, there's been a shift in the overall distribution of intellectual abilities in the population. So historically, approximately 3/4 of people with ASD used to have IQ below the normal range. Now it's the reverse, so that a lot of the increase in prevalence is because we're recognizing more able children with ASD. We've run several focus groups as part of this educational project and heard from people around the province that, in fact, many of the children that are coming to attention for comorbid psychiatric disorders, those children with intellectual abilities in the average or above average range. Now, worldwide, the commonest comorbid condition with ASD is ADHD, and it's also the most common misdiagnosis. It's perhaps not so much a misdiagnosis as a partial diagnosis, and the reason is easy to understand. If families have a very overactive, impulsive child, that might be the first thing they complain about to a mental health professional, and if the professional isn't extremely conscientious and asks enough questions, the fact that the child also has significant social and repetitive difficulties might be missed. So in today's webinar and the one that follows in a few weeks' time, we're not going to be dealing with ADHD simply because the recognition is not usually a problem and the treatment is well known to most clinicians. There have been many epidemiological studies of comorbid psychiatric disorder in ASD, all of which find elevated rates. We're showing here some BC-specific data. So this comes from the needs survey that was carried out by Jonathan Weiss and colleagues a couple of years ago. And these are responses from about 300 odd family members in BC, just describing whether or not their child was affected by a psychiatric disorder. And these rates are significantly elevated above the population base rate. If we look at some of the epidemiological data, it's not uncommon to find rates of anxiety as high as 50 to 70% in children. The other category, of course, covers a wide range of things, but one condition I'd like to particularly draw your attention to is eating disorders. There's been a realization over the last few years that perhaps as many as 30% of girls and young women with eating disorders also have ASD, which usually has not previously been diagnosed. Of course, these are usually, if not always, girls with intellectual abilities in the normal range. We're going to be returning in the next webinar to dealing specifically with the diagnosis and management of anxiety, depression, and OCD, both because of their prevalence and because of the impairment that they cause to affected individuals. Now, we're having these webinars because these comorbid disorders can, in many instances, cause more impairment than the underlying ASD. They can interfere with the child's treatment, whether it's behavioral intervention or treatment by social skills training or speech and language pathology training. They can have a profound impact on the child's functioning at school. Anxious children cannot concentrate on their work. Children who are depressed are not motivated to study. Children who have obsessional ruminations may not be able to complete the most simple task because of thoughts that are repetitively going through their head that other people may not be aware of. And all of these conditions, of course, can impact on home life, either directly because the child is symptomatic at home or because the child is letting off some steam at home to do with difficulties that these impairments caused at school. And overall, mental health disorders in children with ASD have the same effect as they do in the general population. They dramatically lower the child's quality of life. And most importantly, they don't go away. Of course, we're used to mood disorders having a relapsing and remitting course, so that prior to antidepressant treatment, it wasn't unusual for people after several years to eventually get over an episode of depression. But left untreated, anxiety and OCD tend not to remit, and therefore just ignoring these difficulties isn't going to be very productive. And in fact, not only do they not go away, the rates of these disorders increase as individuals with ASD move into adult life. So this again is Jonathan Weiss's data, now probably from about 80 families who had an adult with ASD. But again, this data is not out of keeping with epidemiological and clinic data from much broader studies. And not surprisingly, because depression increases so dramatically post-puberty, we're seeing a very significant increase in the rate of depression, and of course the rate of mania and hypomania, although this is much less common than depressed mood. A small percentage of people with ASD do develop a psychotic episode, usually in late teens, early adult life. Very, very rarely this can be schizophrenia, but much more commonly this will be a stress-induced psychosis, usually because the individual has been placed in an environment, perhaps university or college or a work placement, where they've not had the skills to cope. The people around them have not realized the degree of stress, and most of us, if stressed sufficiently enough, will start to develop psychotic symptoms eventually. Now, one occasionally hears clinicians and parents express the view that these disorders, particularly anxiety and depression, are simply a consequence of the impairments caused by social difficulties, lack of understanding of the world that one is moving in. And of course, those are significant environmental stressors. But it's not the case that if one provides optimum treatment for ASD, that means that the child is not going to develop some sort of comorbid disorder. And the evidence for this really comes from so-called family genetic studies. This is where a group of families is selected on the basis of containing one individual with an autism spectrum disorder, and then the nuclear family and often more distant relatives are assessed for the presence of ASD-related conditions and other psychiatric disorders. And we've known really since the mid-1980s that if one looks at the relatives of children with ASD, the rates of anxiety and depression in relatives are dramatically increased, and perhaps most tellingly, they're increased in relatives who are not living in the same home as the individual with ASD. So this is not simply a consequence of any stress associated with bringing up a child with ASD. And so we believe that the etiology of comorbid disorders in individuals with ASD, both in childhood and adult life, is multifactorial. Yes, there are some impairments that are secondary to the underlying difficulties associated with ASD, but there are probably genetic risk factors that in some way contribute to ASD itself, but are also involved in some of these other comorbid disorders. So if these disorders are so common, why are they so frequently missed? Why do they appear often very late in the development of the disorder? And I think we can break this down really into two types of categories: things to do with the child, or indeed the adult, and things that are to do with the environment and the perception of adults around the child. So in everyday life, we're used to recognizing that our relatives, our friends, our work colleagues are suffering in some psychological sense because they tell us by their facial expression. If we're miserable enough, we look unhappy. If we're anxious, our brows are furrowed. We look tense. We comment on these sorts of behaviors to people around us and express concern. But of course, people with ASD show often a very reduced range of facial expression. Quite often, the predominant expression may be very obviously neutral, interspersed occasionally by clear smiles when the person's obviously happy. But we won't see that sort of moment-to-moment change in expression, which is both, on the one hand, a clue to what's going on in people's minds, but also giving us clear clues about people's emotional state. And in a similar sort of way, we're used to knowing whether people are feeling low or worried about something by changes in their tone of voice. When we're miserable, we talk more slowly, more softly. If we're anxious, there's rather more edge in our voice. The rhythm of our voice changes. But again, this is difficult to pick up in people with ASD, who often will have unusual prosody to begin with. And often the clue is that an individual whose prosody has got better over time may revert to a much more unusual prosody when their mental state changes or they're acutely unwell. Additionally, there may be no clues that there is a separate problem underlying the child's behavior, because what we're seeing is simply a worsening in existing repetitive behaviors. So the child who is more anxious may engage in more motor mannerisms, may be more resistant to change, more insistent on routines. And so it may not cross an adult's mind that actually this change is not just some random fluctuation, but indicates the presence of a separate pathology. And perhaps most importantly of all, very often children with ASD will show their psychological distress in a very non-specific way. They might have temper tantrums, they might have what parents call meltdowns, or just be generally irritable. In other words, there's no clear clue from the child's distress as to what the underlying problem may be. So, in adults with good language or verbal children and teenagers, we expect people to be able to report their psychological experiences, to be able to tell us when they're worried or miserable or fearful of something. But this is really quite a profound impairment, both for children and adults with ASD, the recognition and correct labeling of their own emotional state. Indeed, in BC, one of the standardized diagnostic instruments we use in the assessment of children and adults, the Autism Diagnostic Observation Schedule, contains quite a big section asking the individual to describe in what sort of situations they might feel anxious or sad or frightened or angry, and ask the person to describe what this feels like inside. And this is very revealing, because many affected individuals will give sometimes a rather stereotyped response to this question, and often it's evident that they haven't yet learned to read the signs that tell us, for instance, that we're anxious or that our mood has changed. And that's really quite a significant handicap, because if you think about it, when you're feeling anxious in a situation and you recognize you're anxious because you've got butterflies in your stomach, or you're trembling slightly, or your voice is warbling a bit, that's a good indication either to pull yourself together or to get out of the situation. And leaving an anxiety-provoking situation is often quite a very sensible thing to do. But if you're not recognizing those clues, then you might persist and remain in a situation long after you're able to deal with it at all. And it's in that sort of scenario that we see these apparently unexpected meltdowns or outbursts. The individual has been distressed actually for quite a long period of time, but neither they nor adults or other children around them have recognized the situation. And of course, children with very limited language skills simply don't have the capacity to tell us how they're feeling inside. So these are all reasons why self-report in individuals with ASD is not the same as in the typically developing population. Now, it's not unusual in the adult world for us to have a bad day at home, at work, and go home and take it out on our family. And usually our spouses are sufficiently understanding that they realize that the angst isn't directed at them. But it's even more common for children with ASD to be suffering from anxiety in one environment and then to express the distress associated with that in another, but actually for the adults not to be able to make the connection in the same way as we can when our partner comes and tells us about their dreadful day at work. And so it's really very important that when we're assessing these children, that we're hearing about what's happening in different environments that the child moves in. Because the situation that is perhaps making a child anxious may not be the situation in which they are manifesting distress. And environment is particularly important in managing children with ASD because although we're dealing here with a very strongly biological and brain-based disorder, much of the skillful management of children and adults is to do with making adjustments in the environment that make the environment more friendly for the child and easier for the child to function in. And so part of history taking is trying to establish, have there been any changes in the environment that impact on the child, which may actually not be significant to typically developing people, but may have had a big impact on a child with ASD. And finally, we need to overcome a prejudice which is common amongst many adults, that all the behaviors that a child with ASD, or indeed an adult, show are somehow related to the ASD. Part of the purpose of today's webinar is hopefully to convince you all that not everything that you see in a child with ASD is directly attributable to that primary disorder. As a very famous clinician once put it, patients are allowed to have more than one disease. So the implications of what I've been saying are that history taking should include accounts from good observers in different environments. This will be usually teachers, teaching assistants, after-school carers, parents, clubs that the child attends, that one needs to inquire very carefully about any changes in the environment that the child moves in that could have impacted adversely upon them. We need to be aware if there's a family history of other psychiatric disorder, because that may be a clue as to what any additional disorder may be in the child. And finally, we always need to have a very high index of suspicion for the presence of comorbid disorders in children with ASD, because they are so common, they're so easily missed, and really, when in doubt, it's always a good strategy to start with the assumption that the child might be anxious and to try and exclude that as the first possibility. So, it's my great pleasure to hand over to Richard Stock from Capilano University, who's going to talk to you about the role of behavioural analysts.